to everybody, just because of timing. We were 20 minutes lagging.
Assalamu alaikum jami'an. Good morning, everybody. Sorry, I was busy with another session, so I was pulled to here. So we're having the live transmission from Iraq, which is a pleasure to have them with us. Dr. Aram Jamal Mirza and his team. So please let's start with the case. The people with me here are well known at the Gulf level and locally, and not to delay things, I think we'll start. Let's start with the case, please.
Everyone, it's a pleasure to start every meeting. We are live from Farah Medical City from Suleiman, Iraq. Before I present the case, I would like to introduce the team today. Beside me is Dr. Trevor. He's from American.
We cannot understand you very well. I think the mask is interfering with the voice. So we need to understand you very well. So if you either remove the mask or change your microphone.
سلام مساء لازم من زحمة سلام عليكم في شيء مكتوب يمكن يا سلام خليك كده احلى You can hear me, Dr. Muhammad? صوت واضح لي. Dr. Muhammad?
It's your microphone, my friend. I think you need to tune your microphone. Okay, so can you test?
Yeah. Thanks, Saran. Test. You can hear me now? The sound is good?
I think it sounds better.
Yeah. Shall we proceed? Saran, shall we please proceed?
Yes, please do.
Okay. Beside me is Dr. Trevor, who is from Lebanese American University Hospital in Beirut. He's the device expert. He had to Ghana to have a comment on the IVRs and the functional assessment. Dr. Musa Shaheen, interventional cardiologist from Farah Medical City, and the fellow have Dr. John and the rest of the team. We are going to present the case, and I think that today we have a lot of talk and presentation about left system. We'll try to implement this to the real world in the class lab. Dr. John, please present the case.
Thank you, Doctor. Good morning, everyone. Our case today is a 42-year-old gentleman. He's an overweight. He basically has ischemic heart disease. He had an inferior story underwent primary PCI for the FCA. He's a smoker, just quit smoking after he had the story. He had a strong family history of ischemic heart disease. Since everyone in the family every two siblings has ischemic heart disease, he's an active person. And he complained of chest pain for the last 6 months. We did an exercise diagnosis for him, and it was positive. For non-invasive investigation for ECG is normal, sinus rhythm with no significant change, ischemic change during at rest. His echocardiography was normal. There was no regional wall motion abnormality. We did a rejection fraction, which was about 64, and there was no significant valvular lesion. His basic investigation was normal. Hemoglobin was normal. Cardiac enzymes was normal. Renal function test is normal, and estimated GFR also is normal. And we did radiography for him. There was a significant left stem lesion. His symptom score was 19. We discussed the option for coverage with the case and had a discussion with the case. Which used the idea of undergoing the CABG surgery, since his younger sibling died just one day post CABG surgery. That's why he decided to choose the PCI as an option of the treatment. And for the rest of the procedure, and will be discussed by Dr. Aram.
Thank you, Dr. Ujwal.
Thank you.
So we are dealing with extremely young man with a positive family history of ischemic heart disease. Actually has got history of inferior STEMI a few months ago and the RCA fixing two stent. Now he's symptomatic with this view, with this lesion. The baseline angio showed there is a lesion in the distal left main stem extending to the ostium of the LAD, and meanwhile the ostium of the circumflex is also diseased. So this patient is symptomatic with a positive functional test. So today we brought this patient to implement the functional assessment. One of the objective is to do functional assessment for this lesion.
Aram, you hear me, please? Aram?
Yes.
This is Adnan. This is Adnan with you. Please ask Juan to decrease the loudness of the voice because there is some issue in the audio on the hearing you. Just to summarize what I hear from you, that this is patient with non-STEMI presented with this angiography.
No, actually, the case it's not non-STEMI. He has history
Yes.
of STEMI.
Now we hear you better now.
Now he was a case of inferior STMI just few months
Yes.
back. The RCA is fixed with two stents. Now he's symptomatic with positive treadmill test, and he has got this angio. So today we brought the patient to the cath lab to implement the functional assessment and the new technology for the distal left main stem and the LAD. Now I want to hear from the panelists, what's your approach to deal with such a case, Dr. Muhammad and the panelists? What do you
Great.
suggest?
I think, well, if you give us 1 minute, we're going to go just through the panelists. Dr. Samih Lawan, as a senior interventional cardiologist in Riyadh. Samih, what's your thoughts?
Well, certainly this is a distal left main disease. It's not clear to me whether the ostial circ is involved, so maybe we need better projections in order to improve it, or plus minus an IVUS. Obviously, the LAD is involved ostially and the mid segment. So we really, in order to risk stratify this patient, I think we have to clear very clearly whether or not the ostial circ is definitely involved and what is the significance of the lesion there.
Would you IVUS or not? Yes or no?
I will do IVUS because it's mandatory, especially that this circ is a large vessel. It's even larger than the left anterior descending, and I think it should be managed carefully.
Thank you, Samih. Dr. Mustafa Shmemri, interventional cardiology from university. Mustafa, involving the ostium of the circ or not involving the ostium of the circ, would it change your strategy?
I don't think it should change this, the strategy, because in any case you have to protect the circ.
Come back.
Because the block in the distal left main can be shifted to the circ, and at the end you might compromise the flow to the circ. So regardless, the ball wiring or protection of the circ is important. But my feeling, if we do an physiological study, you might not find significant compromise of flow for the circ. However, the LAD is significantly diseased from the ostium involving the distal part of the left main.
Thank you. Dr. Jassim, would you do a physiological study on this case?
Well, certainly not. Certainly not. I wouldn't do any physiological study for this patient, but I would start with imaging the left main, LAD, and ostial circumflex and find out the differences in sizes. It seems that he has a codominant vessels. He's a young chap with 42 years old, premature atherosclerosis. I'm sure there is a huge black burden on that left main and the LAD and circ as well.
Okay.
only
so,
is the
so IVUS is your
it's
standard.
a true it's a true bifurcation. I think it's
to
one
understand the
one
anatomy,
bifurcation.
understand which strategy you will think of.
Well, honestly speaking, I will go for a crash technique here.
Dr. Matar,
Adnan, yes. Dr. Aram, I think I was indicated is in this patient and also physiological study, if available, it is important because the ostial circ is not so clear between the intermediate. So also it is preferable that hybrid imaging is very essential to see what we call the modification of the, the plague, but I think it is not so available like NERS IVUS.
so
What's your
what's your preferred strategy on this? What's your number one strategy that
IVUS.
No, and technique.
Yeah, a technique, double wire, and we try if the left circ is, the ostial left circ is not jeopardized, we can come through a crossover technique and so on.
Okay, Dr. Aram, can you give us
Yes.
what's your thought?
Yeah, thank you very much. Initially, we have a cylinder 7 French sheath, and you have got ABU 7 French catheter. Actually, the plan is to do a functional assessment for the ostial of the LAD lesion, and to do later to be followed by the IVUS for the LAD distal left main stem, also to have the IVUS for the ostium of the circ. So that's our plan. So possibly we are going to start with the functional assessment of the LAD. And after that, we are, according to the result, we are going to do the IVUS for the left main stem to the LAD and then the ostial circ, because circ seems to be big, however, is not dominant because the RC is dominant. So the plan is to start with the FFR, if you agree with me. We are going to do DFR, conch, and FFR for that LAD, left main stem LAD, to be followed by the IVUS.
What type of sheath you use, Dr. Aram, for this radial approach? Is it left radial or right?
It is right. It's right. It's seven French cylinder sheath. It's 7 French.
Okay.
So we are
Okay.
going to take the FFR wire. Just already have.
So you're using FFR right now, right?
Yeah, we are starting with the FFR.
So
That's our plan.
just by show of hands, who will do FFR? Start with an FFR in this case. Who will start with an FFR in this case from the crowd? You are all interventional cardiologists. We have only one hand here, Dr. Aram. So that's we will go with you. We will follow your
We
way
want-
and.
Today we have a lot of presentation about the left main stem, applying these
Sure.
functional assessments.
Sure.
So we try to translate these to the.
Who will
results
start
in
with
the
an
cath lab.
IVUS?
Yeah.
We'll start with an IVUS.
Sure.
Anyhow,
So over the IVUS.
so there is a lot of people supporting imaging.
Yeah, yeah, there are only 2 minutes. We are going to do it within 2 minutes, just to explain for the audience the importance of the functional assessment. Now we are going to put the wire there in the left main stem, and we are going to please equalize, normalize. Now you should have the PDPA off.
Flush with water.
Yeah, flush, please. Let me remove this one.
Equalize.
Equalize, please. So we are going to do the FFR only for the left main stem, left main stem to the LAD, and to be followed by the IVUS for the ostial circ and the LAD.
We are okay.
Okay.
Sorry, Aram, because of the voice, we don't introduce you. Dr. Aram Jamal Mirza is a consultant interventional cardiologist, Suleimania Cardiac Center from Al Farouk Medical City, and he is at the head of cardiology department, Al Ain Iraq University and Al Ain Medical College.
Cranial, please. So,
Dr. Aram, this is Dr. Jassim. Can I ask you a question?
hi, Dr.
You have a positive stress exercise test. Is that will not be enough for you to prove the significance of this vessel?
It might be one other reason, just to be on the safe side. We are dealing with a young man. He's only 42 years, and we know there is a lot of blood burden. That's why we want to be on the safe side when we are putting, and to choose the strategy what strategy to be used, whether it is the provisional stenting or upfront or making the provisional stenting. So that's why we are choosing, this is the normal. Normally, we are doing the case of left main stem, especially in this age, to be assessed with the functional assessment of the left main stem.
Can you all see the graph and the FFR machine? So now it's the DFR, please.
DFR. Now I'm going to show you the DFR.
So it's clearly positive, Dr. Aram. The DFR is a 0.79.
So if the DFR now is 0.78, so it means that it is positive. So for the time being, Dr. Shabal, do you think now it needs to give adenosine, or DFR is fair enough to decide this lesion is significant because the DFR is 0.83? What do you think?
In my opinion, I think I would have enough data from the DFR and the severity of the lesion. What does the panelist think?
What do you think,
Yeah,
Dr. Muhammad? We have a positive DFR before giving adenosine. The DFR is positive. It's so. What do you think?
Yeah, I
Are we
mean-
going to proceed with
We
the
have a very
FFR.
nice graph, and we have
Yeah, Dr. Aram, I think the argument here, as Dr. Jassim clearly stated, this patient has a CCS angina 3 presented by you, has a positive stress test, and by angio has what look very significant osteal LED. You have confirmed that an additional test, which is, I don't know how much your budget in your cath lab, but definitely I would be worrying about your budget, because in my opinion, we have to be very selective on choosing the modality that actually changes the outcome for our patient. Anyhow, I would recommend intervention on this gentleman. The question is, what will be the best strategy? Would you like to FFR the circ?
If you like, we can do FFR the circ, or we can do
Because you have the FFR already on the table.
Okay.
You have already the FFR on the table. Why don't you FFR the circ, and then we can have a more discussion.
Good idea. Come on to the P coder. So we are going to do FFR for the osteal circ.
Dr. Prashant from Oman. The FFR of the circ will not make any.
Dr. Samih Lawand has a comment, please.
Excuse me.
What about Dr. Aram? What about if the FFR was negative? Would you not have done the procedure? Because in my opinion, whether it is positive or negative, I'll have to do it. This is a life-saving intervention. It's very rare to have a PCI with a life-saving intent apart from acute STEMIs. So to me, this FFR only told me that the LAD is not healthy. This is my way of interpreting the
We have
information.
a question from the crowd there.
Dr.
Please.
Prashant from Oman. The left main
If you
intervention-
introduce yourself first, please.
Dr. Prashant from
DFR,
Oman.
please.
The left main intervention is basically
Nice.
done for prognosis. So the question is, the FFR or the physiology doesn't going to make any difference.
So
Okay.
is it the left
imaging
main or
is
the osteal
important.
LED?
Whether to
Is it
see
the left main
upfront-
or the osteal LED, doctor?
Imaging of both circ and LED and left main is important, whether
DFR,
upfront
please.
two-stent strategy, or you are going to do provisional. If the IVS of the circ doesn't show significant disease, you can go for a provisional. If it shows significant or
negative.
more than 70%
Negative,
disease, or the MLA
So you're
is
going
very
to do
small, then you have to go upfront two-trend strategy, either decay crash or.
So the DFR, so
Thank
the
you.
DFR on the circ is negative. So
Negative.
it's strictly negative. So what do you think is more severe, the
It's not
osteal
negative.
LED or the distal left main?
Exactly. So what do you think?
So the
Shall we-
FFR, what's your FFR on the circ?
One.
It's one. It's DFR
Okay.
one. It's one on the circ.
All right.
So
Okay.
the plan is to do
So what's your plan?
is to do IVUS. We are going to do IVUS to do IVUS for the osteal circ and the LED, and to see the morphology of the plaque in the distal left main stem and the LED and the osteal circ. What do you think, Dr. Sharp?
Yeah, I totally agree with you, Dr. Aram. IVUS is imperative in left main
Why-
disease
why-
and osteal LED disease. So this will help us plan the procedure and
I'll change
would
it.
guide
I'll
us to
change it.
do further intervention.
So
What do the
So are you
PLs think?
gonna, Dr. Aram, are you gonna use the two-stent strategy or one stent?
I don't know. I depend on the result of the imaging. Let me do imaging and to see the behavior of the plug distribution across the distal left main stem toward the LED and toward the circ. Because all the time we want to make the life easy, we will try to complete the case with one single strategy, but it depends all on the imaging. So let's do IVUS and to see what's going there, and then we can decide together what strategy to be chosen for treating this distal left main stem.
I received a message from one of our panelists questioning what about cabbage. Do we have a surgeon here?
Yes,
Please.
of course. Of course. Oh.
Will he bypass both the LED and the circ or just the LED?
So if you introduce yourself, please, and
No, I'm doing IVUS on that. IVUS, please. Yes.
Ahmed Al Arifi, National Guard.
I'll be behind the IVUS, Dr.
I was asking this question myself at the beginning.
Cranial.
42-year-old young, but we don't know what are the comorbidities he has for the team to decide to go for left main BCI and proximal LED lesion.
Okay,
So I
IVUS.
don't know on what basis they have gone through this pathway. Personally, my advice, I will advise for his age to go for CBG and to identify, like what he said, the left main ostial is not severe lesion, so he might benefit just from
No,
limit.
IVUS.
so you're gonna do like just a lima to LED.
Yeah,
mid-cap.
prognostically, long-term longevity will benefit from it for sure.
Okay.
Thank you very much, doctor. Already the option of CABG have been discussed with the patient and with family and with the surgeon. Actually, in these cases, the surgeon is not sure whether you are putting only lima to the LED or are going to put the SVG on the LCX or obtuse margin, because still we are not sure whether this lesion in the ostial of the LCX is significant or not. Because in the FFR it wasn't significant, while angiographically it have been involved. I don't know how many surgeon is available there in the room. If you put this CT for the surgeon, I don't know how much of them saying I'm going to just put in a lima to the LED, and how much they will say, oh, I'm going to do a graft on the obtuse marginal. This is also a controversy, the debate and controversy. And actually, as in the history, we mentioned that one of his brother have been died one day after surgery, after exploring the wound for possibly for bleeding. That's why they have got psychological trauma from bypass surgery. It was an option initially, but however, it's a low syntax score. So I think that PCI is a good option, but after knowing which strategy you will choose according to the IVUS finding. Pay codal, please.
Right.
Now we are going to do IVUS for the LED, left main stem to the LED. And Dr. Sherbel will get his comment on the finding, please.
So for us and for the crowd, Dr. Ram, your question that you need to answer by your IVUS is the extension of the disease in the LED or sizing, or what exactly your question that you need to answer?
Very good question. For this IVUS, we are going to see first the lesion length, the length of the lesion, to see the site of implantation of the stent. Second, the morphology, plaque morphology, whether it's calcific, whether it's fibrotic, whether it's lipidic. And the third, to see the real size of the real size of the vessel. So these 3 points are very important when we are doing IVUS. So they're going to explore these. Now,
so where are we with the IVUS? Where are we? Is your IVUS catheter in now?
Yeah, it's in the mid LED. Now we are going to do the pull back, automatic pull back. It's on 30. It's ready, the device for pull back. Yeah. Now we are going to do pull back.
Dr. Mohammed, and geographically that there is looking that the left main stem LID there is a big discrepancy by the angiography. That's why the IVUS is essential in such situation. But sure, the IVUS will not provide us about big information about the vulnerability of the plaque and its component and so on. So it is for this the link length and extent of the disease, any calcification, and the discrepancy will be
Pull back.
provided by the IVUS.
Pull back, please.
Can we enlarge the screen for the IVUS and make it the main screen so we have a better image?
Okay. Okay.
Of the, yeah, that's
Okay.
something I like more. So can you explain to us
This
where are
side.
you now and where is your catheter and just to know and
Now,
exactly?
yeah, we are in the mid LAD. The IVUS is in the early distal part. Now we are starting to have automatic pullback for it's on 30 seconds. So it's ready, the device?
Yeah.
Let's the technician. Shall we start the pullback?
Yes. Pullback has started.
Okay,
now we
so
can see
pullback it has started now. We are
Where
again
are you,
pullback.
Dr. Aram, where are you near the septal branch now?
Now, yeah, we are just close to the septal branch.
So here we can see a nice place to implant our stent.
You can see the image clearly, or make it the main screen for you.
We can see that this vessel is of a good important size, at least 3.5 LAD. And we can see some circumferential plaque is fibrocalcific with some calcium. If you can see at 4 or 5 o'clock, we can see the beginning of the circumflex, which is not very diseased. The left main, the distal left main is diseased. And here is nice circular place in the left main to also implant our stent. The opening of the left main is free of any disease, so we don't have to protrude out of the left main if we need to treat this percutaneously.
So Dr. Sherber, can you tell it the finding, please, and the left main stem and the LAD, the size, the morphology?
So today we are using the new Avigo Plus device, which has automatic
So you can come out
lesion
to go to
assessment.
check.
We can we have bookmark.
Yes, IVUS.
Does the panelists see the IVUS clearly?
Dr. Muhammad, can you see the IVUS clearly on your screen?
Yes, we see it. Dr.
this is- Yeah.
Thank you,
Dr. Lawan, Samih, what's your take on this?
Yeah, I'm just trying to understand the relationship between the distal left main and the osteal LAD extent of the disease.
Yeah, so this is the
I have
osteal
not
LAD
seen the
on
numbers.
IVUS.
Based on what they are showing,
Yeah.
the left main is actually reasonably preserved.
So this is the
And geographically,
this is the-
it's different suggestion. So maybe we were
Yes.
too quick. Can we go it step by step?
Okay, so
Can
are you
we
seeing
see the
seeing
pullback
IVUS?
again? Can we look at the pullback again, Dr. Aram?
It was
Can we
Yes.
see that
Now,
the
Dr. Sherber,
proximal LAD pulling back to ostium and to the left main, just to revisit that area again.
okay, this
So
is the
this
pullback.
is the pullback. Are you seeing it? Are you hearing me and the panelists?
Can you hear Dr. Charbel? He's have a comment on the IVUS, Dr. Muhammad.
Now this is it.
here.
This
Here we
is-
are.
So this
Here
is
we
this is the left main.
No,
This is the left main.
So this is the osteal LAD. You can tell them, Dr. Aram, this is the osteal LAD
This is the osteal LAD,
with an MLA of
Yep.
4.2.
and the MLA is 4.2. This is the osteal LAD. The MLA is 4.2,
This is the very ostium
3.7.
at the polygon of confluence.
and this
We
is the
can
area
see
of the conference.
circumflex here.
And the beginning, this is the circumference. You can see the circumference. It is the MLA is
78.
78.
And
Yeah.
here is the osteal distal left main,
This is distal left man.
which is somehow preserved, but with a significant disease.
It is
involved.
preserved, but significantly
And
the
the
MLA
plaque
is
burden-
9.19,
And a plaque burden of 67%.
and you can see the plaque burden of 67%, and in the mid of the left main stem
Of the distal left.
and the distal left main stem.
Great. So, Dr.
Okay.
Aram, just a quick thought for our crowd. How this IVUS actually gonna change your strategy?
Yeah, it depends on the doing IVUS for the ostial circ. Let's have the IVUS for the ostial circ. At that time, it will be so clear. If the ostial circ is also significant at that time, we are going to discuss and possibly we are going to start with the upfront to stent strategy. But I think it's too early to decide for the technique that should be chosen for this patient. Let's do the IVUS for the circumflex, and accordingly we can answer the question which technique should be chosen. That's
Dr. Jassim,
if you
what do
agree
you
with
think?
me.
Anybody
Well,
has
from
a say
looking
on
by
the-
looking at IVUS, it seems that the LAD is severely atherosclerotic down the mid LAD
Yes.
until proximal ostial LAD.
Yes.
But there is, in fact, I did not see significant lesion along that vessels except in the ostial LAD. I can see the ostial circ looks fine in the IVUS.
Yeah.
The opening of the circ looks
Exactly.
moderately fine. So that's give you the 101.
Yes,
So what,
exactly.
So I will go professional stenting really here.
Provisional
So-
standing, okay.
So professional.
Dr. Adnan?
So
Dr. Aram, I totally
Dr. Aram,
agree
can
with
we
the
have the
panelist.
Aram
I will go to the provisional stenting. That's why,
Okay.
because the left circ
IVUS.
ostia and geographically as well, and by the extent of the disease in the IVUS also no extensive
Community
involvement.
social
So I
Last
prefer
question.
provisional stenting.
Flush.
Okay, so if you
Okay.
like, we are going to do IVUS. The IVUS is the catheter. If you like, we can do the IVUS for the LCX to be on the safe side, and accordingly, we can choose our strategy on the basis of the IVUS finding. What do you think? Shall we go with the IVUS for that, or just we are going to do pre-dilatation for the lesion and to be followed?
IVUS run to plan if we have any problem.
Okay, if within 1 minute, we are going to do the IVUS for the circumflex. Go, please.
Hello. Sorry.
Yeah. He's
Laura?
asked me, should I do IVUS to the circ?
Yes.
No. I mean about the strategy.
I think you've done the FFR to the circ and it was not significant. I wouldn't really, and
Yeah.
you build back the circ looks okay. I wouldn't really IVUS the circ right now.
Mm.
I would think of the strategy based on that the significant lesion end before the left main, and the question
Yes.
is what really the strategy here. And we got two talking about provisional stenting. I think Mustafa.
Yeah, well, I think it's a professional stenting because the
Yes.
ostial circ is preserved, is not involved at all. However, the double wiring will still be there. And I'm not sure that the surgery has any role over here because if the patient had
Pull back.
FFR of 0.83, which means that the competitive flow with Lima, it will be there and the patient might
Yes.
have closed Lima. So we are
Yes.
now treating a borderline lesion in the left main, and the professional stenting will be the way to go, and most likely it will be successful.
Yes, it is good. I think that this case will be ended with the provisional stenting, because we want to explain more about the role of the imaging for the left main stem. But my gut feeling is that it needs only provisional stenting, just pre-dilatation, slit, stenting, pot, and that will be the end of the case. But let's explain for the audience how important is imaging, how important is functional assessment and dealing with left main stem. That's the aim behind doing the IVUS. Shall we do pull back?
Yeah, can I just, Dr. Aram, can I just pose a concern?
Yeah.
When the IVUS told me that there is now significant involvement of the distal left main, positioning of if I decided not to do a crossover stenting from the left main to the LAD and decided to do an ostial positioning of the stent towards the LAD, how would this technique affect your decision? I have my own explanation, but I really wanted you as the operator to tell me how these two strategies will make your decision appropriately.
Oh, thank you very much, doctor, for this question. Really, from angiographically and from IVUS, it's so clear that the distal left main stem have been involved. There is the plaque burden of about more than 67%. So I don't think that there is a way to put the stent in the precise ostial LAD because you have got a plaque in the left main stem. So for this case, I will never put a stent in the ostial of the LAD because there are a lot of plaque left behind in the left main stem and possibly some in the ostial LCX. So putting precise LAD stenting to me, not an issue and not a case in this particular case.
The panelists see the run. The
Doctor, please introduce yourself.
And excuse me, this is the run of the IVUS. This is the IVUS run for the LCX. Dr. Sherbel will get.
My name is Umair Ali. I am from Iraq. I think there was some confusion regarding the FFR. It was a DFR, not FFR. And DFR, we know when the value is above 90, the reliability is decreased to 40%. So in such cases, I think FFR is necessary to be done if you want to assess the functional assessment of the CERC ostial lesion properly. This is the first. The second one, I totally agree with Dr. Aram. I think IVAS is a good idea to do for the CERC to make sure before the intervention and after the intervention whether there's any significant plug or not, and then the decision will be made accordingly.
Thank you. Thank you. I think
Yeah.
for the sake of time, we'll try to move
Yes.
quicker. Dr.
Yeah.
Aram,
So
please
this
show
is
us the
ostial
IVUS.
circumflex.
You can see the osteals. You can hear Dr. Sherbel, please, Dr. Muhammad.
We
Can you-
can hear, yes, when we can see.
Okay.
So this
Okay.
is the pullback. This is the pullback from the circumflex. You can see the circumflex is a major vessel here. It has an approximate diameter of 5. We can see that there's some disease infiltrating the circumflex. We are nearing to the proximal part. We can see here that the disease is more significant. And here at the takeoff of the marginal branch, we can see that we have approximately 30 to 40% plaque burden. And here at the ostium, we can see that it's infiltrated with disease with a good MLA, however, and no severe stenosis,
Yeah.
only moderate lesion. I think that this MLA for the circumflex is okay. We can see
Yes.
here at the ostial LAD. What do the panelists think?
So what do you think? We have disease
We have
ostial
a
LCX.
6 millimeter square of minimum lumen area, I guess, in the ostial circumflex, at least.
Do you think this will
This is
change the
ostial
strategy?
circumflex.
This IVAS finding will change that strategy for treating such a patient? The MLA, Dr. Sherbel, is 8.5?
Yeah, the
The
MLA
A-
at
the MLA is
circumflex
8.5.
8.5. We can see
This is in
clearly on
keeping
that.
with our expectations, and I think provisional stenting remains the mainstay of the decision that we should do.
So we all agree on provisional
Okay.
stenting. Dr.
So-
Aram, we are moving to the last LAD pullback. We can
Yeah.
see on the automated assessment that the lesion length is approximately
So give me
30
balance
millimeters.
3.515.
The distal reference vessel,
Yes.
I would put a stent of 3.5 millimeter. We
Yeah.
have a lumen of about 3.5.
Proximal LAD.
Yeah,
And,
so 3.5.
all right.
It's we have a plaque of less than 50%, so it's a nice place to implant our stent. What do
Okay.
the panelists think? Any other opinions?
Any other thought about the IVAS finding regarding the sizing of the stent and
So what's the sizing we're talking about? The
3.5.
The LED
It
is a
is-
3.5.
yeah, LAD.
And what about the left main?
The left
We
main, it
need to
was,
know the left
It's
main.
fine.
What's
It's
the
fine.
measurement for the left main?
Dr.
It's
Sherbel,
fine.
it was 5, yeah. So we're going to do
So-
pre-dilatation with 3/15 for the left main stem toward the LAD to be for
But this poses us with a problem of this the discrepancy in size. So I wonder whether a 3.5 and a 5 millimeter left main would suffice our needs, except if you select a certain device that can go up
Yeah.
to 5. I don't know.
Yes. Actually, we have the
Sure.
stent. The stent is 3.5, can be expanded up to 5. That we have chose the stent. Yeah, exactly, because there is a big discrepancy, 0.5 milliliter. So that's milliliter. That's why millimeter. That's why we chose that platform of the stent. That 3.5 can be expanded to 5.
So that's the
Yes.
importance
Yes.
of
Yes.
imaging.
Go.
So we are
14.
doing actionable imaging to take action based on what we find on IVUS. So we chose a 3.5 by 30 stent.
Okay.
So,
We are going to
so Aram,
pre-dilate.
just to be clear, you are using a 3.5 balloon?
Yes, it's a 3.5, 15.
Ballooning across the ostium of the LED?
Yes, exactly.
With and the left main. Dr. Waqar?
Yes.
Okay, Waqar Habib from Jeddah.
Semi-compliant, Aram?
It is semi-compliant, aware and Boker. Yes.
Yes.
Okay.
Aware and Boker.
I think our audience really need to know which 3.5 stents go to 5.5 or 6, and it's not all. And by name, you need to have at least one in your lab that does it, whether it's a Megatron or Nagomi, Terumo, or any of them. Not all 3.5 drug-eluting stents. Can
Which stent you are planning to use, Aram?
I am going to put Onyx Truco. The Onyx 3.5 can be gonna to 5, not 5.5, because the real
So
size
using
of
Onyx, okay.
Yeah, and you can show you can
Okay.
have an Onyx of 3.5. So the size, the next Dr. Sherbel by Ivers, it was 22 or 26. The length
I would take a 30.
30.
Yeah.
So,
So there's a nice landing place
yeah,
just after the septal.
I think, I think your IVUS can help you there.
yes.
You
So, yeah,
started
we can
from
see
mid-distal LED, so you'll be able to actually
just one
position your
observation.
stent well.
The
Okay.
left main is 5.5. It's not 5. So if you're going to use a stent, I would use a stent that goes up to 5.5. If you look at the IVUS image, the left main is clearly a 5.5 millimeter vessel, at least.
Dr.
What
Sherbel?
about
I think the Onyx would go
Dr.
to
Aram?
5.5.
What
Yes.
about
It
if
will
you
dilate
consider a 4 millimeter stent at
We
low
are-
pressure towards the LAD, and that can probably reach 5.5 with the expansion in the left main? I would have suggested that.
Yeah, we have Ultimaster that is go only to 5, 4, and Onyx Truco the same. The platform is 3.5 and 4 can be expanded up to 5. And I was Dr.
They
Sherbert.
can go up to 5.5 easily.
Which one?
The Onyx.
The Onyx. So we
You
can go
agree?
with the Onyx to 5.5 according to the IVUS when we are doing pot and doing IVUS. So we
Dr.
don't.
Aram, this is
Yeah.
Dr. Jassim. Can I ask you a suggestion from my
Yeah.
side? I would really, because of the discrepancies between the sizes of the LAD and left main, also I see
Yeah.
double size left main LAD. I would
Yeah.
go to stent strategy.
Mhm.
I will go to stent strategy for LAD. Maybe you can take a short stent of 18, but you go with a high stent with a 4, perhaps in the LAD and left main.
It is a good strategy, but the problem is that 3.5 and 4, both of them can be expanded up to 5 or 5.5. We can use that, but the reference diameter for the LAD pair of IVUS, it was 3.5. That's why we can put 3.5 and 4 to have 1 millimeter overlap between them. This is an option. I don't know what about the panels, what they think.
So,
Put into stents.
Aram,
Yeah.
do you have the stent on the table or not yet?
Yes, it's not yet.
Who's going to use a 3.5 just by a raise of hand? Who's going to use 4? Okay, I think we have an equal crowd here. It's your
Yeah.
call. It looks like there's a divided group here between 3.5 and 4. The panelist here feels more toward the 4, but it's your call. You're the operator. Thanks God there is only maximum 2 people inside the room who can make the call. Otherwise, we'll never finish the cases.
Yeah. So I don't like to have overlap in the proximal LAD to prevent future failure of the stent. So to me, I'm going to choose only one stent, and I'm going to have aggressive post dilatation for the proximal LAD and for the left main stem. To me, I would like
You have
to
50,
prefer
you have
that.
50% support here, so you
That's
should
good.
be okay.
50 is good. With me, 51. That's good. So stent 3, 30.
Is it 3.5 or 4, Dr. Aram?
3.5. He decided
It is
3.5.
Because
He decided 3.5.
because the size of the LAD is 3.5. It is very hard to implant the 4 stent and the 3.5 LAD vessel diameter. So we are
I
going
think
to put
I
that.
think the I think
yeah.
the IVUS after your stenting will be the judge for
Yeah, but I
Yes.
think less than 4 in the left main is very unlikely to be a good choice.
So we
It will
can
reach
take
5.
4. It doesn't matter. We can take the 4 and.
Oh, you're changing your heart now.
We can
He's
make
changing
it
your heart now.
49. Yeah.
So are you taking 3.5? Let's be final or 4.
To me, I will take 3.5 for the sake of the LAD.
And we'll post dilate.
Yeah, because I'm going
Alas,
to
go
do
ahead.
aggressive.
Go ahead.
I'm going to do aggressive.
3.5 Onyx stent, and you're going to do a max dilatation at the left main, reaching it to
Yeah.
5 point
Yeah.
something maybe. We don't know.
Hopefully.
We'll see the IVUS.
Yes. Okay.
And the length decided based on the IVUS, or
It was
just
30. It decide according to
Okay.
the IVUS. Dr. Charles
sort of
said that it is-
eyeballing?
Yeah, it is 30. So that's why, according to IVUS, we have chose the length of the stent.
Okay.
So what do you think? Shall we put the stent implant in the ostium or to spare few millimeter in the ostium of the left main stem?
I wouldn't
What's-
extend it, Dr. Aram, to the ostium.
Yes.
Just we would spare a few
I
millimeters.
want to ask, okay, I want to ask the panelists, would you like to implant in the ostium or to put it just to spare few millimeter in the ostium? Iliocranial, please. What do you think,
Taking into
Dr. Mohammed?
consideration, Dr. Aram, that the cleanliness of the left main and the side of the left main does not oblige me to go
Yes.
back to the ostium. So I go midway through the shaft. That will be
Yes.
satisfactory enough.
He called on this.
But
What do you think?
Going to the mid LAD shaft will be problem with the pot because you need to use a higher balloon. So I think you should either,
Unless you're careful.
because you have a not very long left main here. So if you go with the middle, you will have a
It's
problem
good.
with the pot.
What do you think, Thomas?
For the cell.
You are using 3.5 for the osteal.
Yeah.
Dr. Adli Riyam from Oman. So we
Hmm?
had a big debate of which stent to use. That's actually the same
Okay,
platform.
good.
3, 5, and 4. I
good.
just looked it
Okay.
up.
Any?
It's the same stent.
Good.
So
Okay,
you,
go.
you use
Same
Translate.
tube.
Yeah,
Same
you-
tube.
Sorry,
The same tube.
it's the same tube. So put a
14?
3, 5, and then post dilate based on your
Okay.
angiographic.
Yeah,
Okay.
that's what
Thank
we
you, Adil.
chose actually. Yeah. So we chose to take a 3.
So we went up to 14 ATM. We spared the ostial part of the left main stem. Just we put it in the, we implanted
So-
it in the mid shaft. We have short. Let's have a
So Aram, you went up to what?
14.
How high you went? 15?
14. 14. 1-4.
14. 1-4.
Yeah, yeah. Well, now we are going to
Okay.
do pot with the smallest 5O balloon and to do IVUS to see what's going there. So can we have balloon 5-8? What do you think? 8 or 12? I think 8 is fair enough for that length inside the left main stem. Can we repeat?
We're not going to argue 8 or 10.
All
You
right.
choose whatever you want.
So let me have balloon 5-8, please. NC balloon 5-8. So we have spared the ostium and the proximal part of the left main stem because it was clear in the IVUS. So this is balloon 5. We are going to do post dilate aggressively. One more checking.
Can you show us a spider view as well?
Yes. Now or after post dilatation?
No, now, because I want to see it with the circ and the left
Okay.
main.
So let's have spider view, please. Spider.
Yes, it looks good, but Spider will clarify it very well.
Yeah,
Okay,
it looks
let's have-
good, Dr. Aram. Well done.
Okay. So let's have angio. So it seems to be not bad. Dorsal circ. Come back
Excellent.
and give me max. Can you have a live stand boost?
Okay.
And we're going to do live stand boost. Just okay, good. Let me have a no. Let me take a stand boost, live
No.
stand boost. You know, for making a pot, you should the distal part of the balloon should be at the ostium. Stand boost live. No, we are going to do live stand boost. Okay. Danny?
Okay.
No, I should go a little bit inside.
A little bit
Yes.
inside.
You can
absolutely.
see the stand boost, so I'm going to a little bit inside. I think this is good. Stand boost.
I will pull back a little bit.
Okay, let's just have it on the stand boost. I will
One more time.
no.
Well, for a future anticipation that the patient might have a circ problem, I would go more proximal with the bifurcation.
Yes, I think this here is good for the pot. Go, please.
Yeah.
Give me
Look
Mac.
like a good position.
20 bar, please. 20. And stand boost. Good.
Excellent. Okay.
So we went 20 bar for the time being, and we are going to have a stand boost. Stand boost ready?
And see 5.
Maybe we need to advance
Eight.
it a bit.
Okay. So we are going to make it again. If you have, look how the left main stem stand become expanded well on the left main stem, but we are going to make it again. I think here is good. Stand boost, please. Here is good. Okay, go. 22 bar. And now 22 bars. It slipped because it is short balloon.
Can advance it a bit.
Because it's
So
short.
how high you went, Aram?
22 bars. Now it's good.
And the balloon size now with that pressure, how it will?
It might
it's actually
be
gone
5.
up. Just check the
4.2. It's going to 5.2 or 3.
5.2. Okay.
Now we can hand Ivers to see what is going there because of the sake of the time, if you agree with me.
Post dilate the LED a bit with a 4.
Okay. Now I'm going
So
to do
will
for
you
the
show us? Will you just show us an angio, just the cine,
Okay.
because we haven't seen the cine yet.
Balloon 415. I'm going to post dilate the LED, Cine. Cine, please.
Show us a cine first.
That's the Cine.
Excellent.
The Ostel Circ seems to be
Yeah.
good. The stand
So
seems to
it's
be
time-
well
Time
expanded.
to Ibis.
Yes. I'll post, let me
The
post
circ,
dilate the LED.
the circ looks beautiful. The result
Yeah.
looks excellent.
Yeah,
The
I'm not
circ
going
looks
to.
beautiful. So
I'm not going to
So
rewire
that-
the
that
circ
was-
for the time being.
that was the right decision, not to touch
Okay.
the circ.
Yes, I'm going to do some post dilatation with the balloon 4 for the balloon 3.5 for the LED, and I'm going to have Ivers run because of the sake of the time. And they are not going. If you don't like, we are not going to recross the LCX and doing kissing. I don't think that we need a kissing in such a case. Sizable LCX and geographically seems to be good. Go. 10 bars. 12. 12 bars.
We have a question here,
down.
Aram, please.
Yeah.
Yeah. Shouldn't we remove the?
Introduce yourself first.
My name is Mohammed Medhat from Egypt. Shouldn't we remove the gelled wire before pot in order not to make
Should
it-
we remove the gelled wire before
No,
we
definitely,
do the?
definitely no, because the drill wire is a marker for position of the distal part of the balloon. So I'll never remove it because they give me a good marker to see where exactly I will position my balloon for doing pot. Okay.
Yeah, we used to be worrying about the gelled wire.
I think this is a specificity for bifurcation in the left main stem because sometimes the gelled wire, if you remove it forcefully, you can deform the stent. But for the main stem bifurcation, we should keep it.
Sure.
And another point to add, this gel wire later on, if you try to recross the circ, sometimes it is very difficult to cross the balloon. It will work as anchoring, guiding that will give you a lot of support just to cross the balloon through the side
Great.
branch starts. So this point. but
Everybody is waiting for your IVUS, Aram.
Okay, I am doing the IVUS within 1 minute. And Dr. Chobo will get his comment on the IVUS as he's professional in that. Now the IVUS is going inside. It's a matter of few seconds to give you the IVUS. All right, good. And geographically, the left main stem seems to be well expanded, but I don't know what will be the IVUS finding here. We are going to see after a few seconds what have we done, please.
We have a question here.
Yeah. I'm Dr. Haider from Iraq.
Yes.
I
Yeah.
have a question here
Can you
about,
advance
about the
it more,
stent
please,
Dr.
Dr. Aram?
for Dr. Aram and for
Dr.
the
Aram,
panelists.
حيدر تقرب على المايك تقرب.
Yeah. It's
Alright,
okay?
sir.
Yes, okay.
Yeah.
pull back, please.
As you know, this is left main stem. And in this cases, we need, especially in young age patient, I think we need for high radial force stent. My question here for Dr. Aram and for the panelists, if there is no high radial force stent, right, Megatron stent, would you go for PCI in elective cases, not in acute coronary?
This
I
was an
don't-
elective or an acute? This was not an elective. This was an elective case.
This is an
This was elective. Yeah,
So-
CCS angina 3.
Yeah. My question in elective cases, would you go for PCI left main stem in young age if there is no high radial force stent like Megatron?
If there is no what?
If there is no high radial force stent like Megatron stent, would you go for ordinary stent for left main stem?
Ordinary stent?
Yeah, not high radial force. As you know, Megatron stent is high radial force.
I think positioning or putting or inserting a wrong stent is
we can see
not
here
the right
that at the
answer.
distal edge of the
I
stent,
wouldn't
the stent is
fix the
very
problem with the wrong
Doctor,
with
can
the
you
wrong
see,
strategy.
excuse me, can you see the IVUS? Can you see the IVUS run?
Yes, show us the IVUS, please.
Okay, the IVUS.
For the sake of time, we need to move quickly.
Yeah. So, Dr. Charbel,
so this is a pullback from the IVUS. I guess you can see it clearly. We are approaching to the proximal edge of the stent. This is the mid LAD.
Yes.
This is the proximal edge of the stent. The stent is very circular, well opposed, well expanded. I can't see any dissections, any geographic misses. So the distal edge is good. Here, the mid part of the stent, which is very good. We can see that we have a nice MLA here. This is the left main. We can see the stent is very well opposed. It's very well circular. It covers all the left main, and we have no dissections. Thank you, Dr. Ram. I guess this is a very nice IVUS.
What do you think, Dr. Muhammad, and the panelists, about the IVUS? What do you think?
The
What's your
IVUS
final
looks the IVUS looks very good, actually. I think this is a beautiful result.
This is the-
I don't know how much time we have. How much time we have for?
This is the MLA and the LAD. It's 8.
Yeah.
The ML, yeah, good. Perfect.
The only thing, maybe the mid part or the proximal part of the LED, and maybe try to optimize it with another NC balloon, and then go back and do the left main again, just to make sure that. So that's just fine tuning, but the result looks beautiful. I think that was the right strategy and the right thing we did to our patient. So are we okay? I think we can close the session. Aram, this was a great case.
Thank you.
Great discussion. We enjoyed it. Me personally, I enjoyed it. So thank you very much.
you.
Wish you all the best and stay safe.
Thank you. Thank you very much. Thank you. See you. Thank you. Thank you very much.
Thank you, Aram. Thank you very much.
Bye bye. Thank you.
We are waiting you for flight تجيب لنا من السماء وياكم سليمانية.
إن شاء الله. بس الشر. Thank you.
من السماء ما تاخذوا